It was in the late 19th century that an orthopedic surgeon named Thomas Morton described a painful affliction of the forefoot that later became termed Morton's neuroma. He and other investigators determined that inflammation of a nerve in the bottom of the foot was the cause of this pain. It's interesting, many studies have determined that probably the incidence in women is 4 times as common as that in men, and this deformity of a nerve or inflammation of a nerve usually occurs or peaks in the 4th to 6th decade of life. When we look at a model of the foot, the most common area of location of this pain is either between the 3rd and 4th toes, or the 2nd and 3rd toes is another area that the pain occurs. The cause of formation of a neuroma is not entirely clear, but certainly it's been suggested that poor footwear may be a common cause. Constricting shoes, tightening over the forefoot has been suggested as the reason why so many more women have this problem than men. But other causes of trauma, such as fractures of the metatarsal bones, or even repeated walking or standing on hard surfaces for long periods of time, may cause thickening of the nerve. And as that nerve thickens, and as it increases in size, the nerve is more commonly traumatized again. And this indeed, over a period of time, leads to the development of a painful neuroma. The history that a patient gives when they have a neuroma is pain in the forefoot, and often it's a fairly vague, large area on the top of the foot. When we look closely, sometimes the pain and numbness will radiate out into the 3rd or 4th toes, or into the 2nd or 3rd toes. Often removing a shoe will relieve pain, whereas wearing that shoe for a lengthy period of time may cause the pain to increase. Often taking the shoe off and rubbing the top of the foot and the bottom of the foot will relieve the discomfort as well. Now let's actually look at a patient and see where neuroma pain may occur. One of the most common and difficult things for a patient to do is to isolate that pain in the forefoot. That's because the foot is a long ways away from the hands, and it's inside a shoe and a sock. And when a person first comes in and is seen for neuroma, often they have this large area of pain that they sense their discomfort in. The challenge for us is to try to isolate that to a very small area. When we examine the foot, we often press the foot from side to side to see if we can cause pain. Sometimes we'll push from top to bottom, and if we get a certain click feeling or a snapping feeling, we actually can feel that neuroma pop up above the ligament in the foot, and that may also cause pain or radiation of the numbness into the toes. So what we try to do instead of isolating the pain to a broad area is to think like an ice pick, where it would be going through the top or the bottom of the foot, or even a pin. And you think of it coming in the top and then coming out the bottom. And we want to isolate that, and so we'll have a patient mark the bottom of their foot so that when they come in the office, they've really honed it down to a specific area of pain, both top and bottom. And I kind of liken it to the analogy of a doorbell. If you push around and you're not right on the button, it won't ring, but if you find the right spot, if you find that doorbell, it will ring. Likewise, when we examine the foot, we're going to push in certain areas around the foot, trying to find the exact location of pain. One of the symptoms that patient will have is the radiation of pain, as I've mentioned, into numbness, or radiation of numbness into the digits of the toes. The other location where a neuroma occurs besides between the 3rd and 4th toes is the 2nd inner space. And if it occurs there, the patient may actually have numbness radiate into the 2nd and 3rd toes on the inner aspect of each of these toes. Now let's look at the anatomy of the foot. In this plastic model, we can see the nerves. We made them out of electrical wire, and it's very simple to see. The black portions are the larger nerves, and the copper portions are the ends of the nerves as they come out into the tips of the toes. Each of the metatarsals are connected to each other by these green ligaments. And those are the actual ligaments in the toes that interfere with the nerves themselves. And it's between these 3rd and 4th metatarsals, which actually is where a neuroma commonly occurs, and there may be some friction or rubbing between that ligament against the nerve. Now let's turn this over and look at the bottom of the foot, and we can see the size of the neuroma in this third interspace. It's an enlarged nerve. It's not a cancerous tumor, but it's an enlargement. And then you see the rest of the nerves branching out into the rest of the toes. Now some feel that the reason for a neuroma occurring is that this region is because of a small crossover nerve between the third and fourth nerve. But we can see that a large nerve, this enlarged nerve in the area between the third and fourth toes, in comparison to a normal nerve between the second and third toes, it's quite a difference. This is the area in which the pain emanates from this out into the toes, and that's actually the area that is excised when surgery is performed. The non-surgical treatment of a neuroma includes obtaining wide, roomy shoes in the forefoot region, even placing a metatarsal pad in the shoe to decrease weight bearing in the region of the neuroma, or even on occasion a cortisone injection into the forefoot area. Now, one of the treatments we can use early on when taking care of a neuroma is to place a small pad in the shoe to transfer weight from the area of the neuroma to the area of the metatarsal. Besides using clinical examination, feeling the foot for pressure and pressure points, we can use injections of xylocaine to anesthetize certain areas of the foot and try to make pain disappear. We sometimes see a patient every 3 or 4 weeks and inject several areas and locations, one each week, to try to temporarily anesthetize the area. If we can make their pain go away for a short period of time, then we can likely localize exactly where that pain is. Now, we inject an area with xylocaine, not with corticosteroids, to eliminate pain for just a couple of hours while the patient walks around in some of their more painful shoes. This is how we may be able to isolate the location of a neuroma, and after 3 or 4 injections, maybe only 1 or 2 is successful, but if they are, then we can find out exactly where the most painful area is. But in time, surgery may be necessary if conservative measures aren't successful. Surgery is performed on an outpatient basis with the foot anesthetized so there's minimal discomfort. The patient does, however, have the option of further sedation if they prefer. Once the outpatient surgery is performed, the patient is typically allowed to leave and go home, usually walking with crutches for a day or so until their block wears off. The patient will use a postoperative shoe with a gauze dressing that is changed every 7 to 10 days. We divide the ligament that I showed you, and you see on the diagram in green and observe the neuroma, and when it's very enlarged, we remove it and then close the wound. Surgery typically takes less than half an hour, and often the patient is home within a couple of hours following the surgical procedure. Although pain medicine is used, pain is typically minimal. Again, the patient is allowed to walk with crutches and a bunion shoe with weight borne on the heel and on the outside of their foot. Office visits are typically had every 7 to 10 days, with sutures being removed approximately 3 weeks after surgery. We use gauze and tape dressings that are reapplied every 7 to 10 days for a period of 6 weeks, but occasionally use Coban wraps as well. We want that cut in the skin and the cut in the ligament to heal adequately. After 6 weeks, shoes such as tennis shoes or wide-soled shoes can be used for walking and light activities. Our more strenuous activities are really reserved for 12 weeks after surgery. The general results of surgery are usually about 80 to 90% patient satisfaction. In our study published from our Boise patients several years ago, we saw exactly that kind of result. But I want to stress the importance of spending time making the correct diagnosis. There are many different causes of pain in the area of the forefoot, and just one of them is an interdigital neuroma. What we need to do as a doctor and a patient is try to isolate that area of pain and get it from a very large area to a very small, defined area. If we can do that, we can be successful. Now, as far as the risks involved with surgery, there's always a small risk of infection, and there's certainly a small risk that a neuroma can return or come back, or that there may be another neuroma in a different area or location. But that's very, very uncommon. In my experience, usually there occurs just one neuroma in each foot. So what's important is that we take our time in making this diagnosis. We spend time together watching your foot and helping identify the location and the level of your pain. The level of success is much higher when we take our time to isolate that area of pain. While conservative treatment is often helpful in treating the early neuroma that's not overly painful, as time passes and pain becomes quite constant, surgery can be necessary. And I believe it's the cooperation of both the patient and the physician in making the correct diagnosis that is the very key to our success. If we can spend time learning about what causes your pain and the effective treatment of it, I think we will have success in restoring your foot to painless function.